relationship. I can give you ample examples of where the pressures of too many patients on the waiting list, not enough rooms to see the patients. A lot of the physical environments, for example, don't enhance patient-physician relationships. And so even the physical environment as well as the intellectual and structural environment, we can have a say, we can try to have a say in how that is structured so that we can enhance the physician-patient relationship. I was going to use the eye clickers, but I decided not to. Because I don't know how we would answer this question. But it basically comes down to two philosophies of science, of medicine. If you go back and you think about what medicine is. Either medicine is a moral commitment to do what's right to the patient, whatever that looks like. Or else it is medical and scientific technology that is used in the benefit of our society. And so I was going to ask for a vote as to how we saw these two things, but I've decided not to do that because I'm not sure what that vote would tell me or tell us. But that's the challenge of today, is to look at your own medical practice and your practice, your interaction with the patients, and decide where do you fit. That's all I have to say. I guess we should open for questions if anybody has any questions.
Just a comment. I really enjoyed this. It was very thought-provoking. If you looked at that slide where you had the physician patients and all the factors, like the students, the university, you had all of those interacting with the physician.
Correct.
And in actual fact, they don't. They interact almost as much as with the patient.
Correct.
And I think that how you view something like that has a profound effect on what you consider to be the physician-patient relationship, because maybe it's almost impossible to have genuinely a physician-patient relationship that governs the interactions with respect to that person's particular health problem at the time.
Right. I agree with you. And I actually deliberately only left it focused on the physician. For two reasons. One is that that was kind of the view I took of what I was talking about today, and also because the slide gets really completely messed up if you do all the arrows that interact together, because everything interacts together. It's more like a web than it is just, yeah. And it makes it very challenging as a physician then to know what is your role in that one interaction. I'm actually, when I went through this, I thought, it's really quite amazing that we have relatively good outcomes and relative good satisfaction from seeing our patients and from them seeing us. Because when you look at all the interactions, you think, how are we going to get this right? But for most parts, it actually seems to work reasonably well.
But if you say, wanted to change something with respect to that relationship, you can't look at it in the model that you presented. You have to look at it in a much more organic perspective.
Right.
And as far as voting, it's number one.
Thank you. Jackson?
Hi, thank you for your talk. I just wanted to have the point of this, what is medicine? And the question is, where is it placed? What is the place of humanity? What does that mean to me and my family?
That's right. And that's essentially what this slide asks in some ways. Is humanity the first commitment, and then the technology secondary to that? Or is medicine science and technology, and then humanity is somewhere just in how we kind of apply it? So where is your focus of it? And I think, yeah, I agree with you. So that's what the Gold Foundation is trying to do, is trying to bring back humanity, the arts and the science, but the art and the philosophy underlying medicine. And that's actually taken on to be quite a big movement in the United States and in Canada, trying to bring back the humanity into medicine.
It's very interesting that we think and talk about humanity, that our thinking, our values could be quite different. You and your family in it or not in it.
Yeah, that's right.
It also assumes, if you look at number two, that science and technology will continue on and get more and stronger and better. And for our and the cultural aspect.
And I think if you look at what patients want, even to yourself when you are unwell, what you want, you don't just want the science and technology.
No.
And I don't think the science and technology will ever truly replace a caring person who tries to help you or who's using whatever technology they have to help you get better. I don't think it can ever do that, because at the very root of it, we are all human, and we are relational beings. And we build relationships, not with computers, not with questionnaires, but with other human beings. And so,
May I just make one final point?
yeah, and then
Just one final point is, the true value of humanity doesn't depend on our current cultural human behavior and preferences.
you know what? I don't have an answer to that. I have a personal answer to that, but I don't know what the cultural answer to that would be. Obviously, the nuances of how it works out will be influenced by the current culture. But whether that's the true answer, I don't know.
Oh, I was just going to disagree with your previous point. We build relationships through computers, through technologies, but also with technology. I do agree with you, we also build relationships with other people.
Right.
But that's precisely why this talk is happening, because patients build relationships with people other than physicians.
Correct.
In medicine, although I would love to agree wholeheartedly with the first comment, I'm not sure whether the physician is always in current medicine, right? So that's why.
Right, and that's why I didn't do a vote for this one, because I don't know which answer would be. They're just kind of thought-provoking statements, rather than one true and one completely wrong. But because we are in a bit of a flux, and also it depends on what type of medicine you practice. If you are an ER physician, you're not going to have a long-term relationship with your patients. You're going to see them and treat them for what they need there and then, and you're going to send them on. Whereas if you are in oncology, you might have a much longer-term relationship.
Thanks, Karina. I think the first reason you didn't ask for a vote is it's impossible in my opinion to separate those two issues. They're clearly interlinked, just as we were hearing from Michael. And I think it would be spurious to ask somebody to separate it in that way, because it's impossible to do that from my perspective.
Right.
If I could ask you just to elaborate just a question as well. Your information about the eugenics movement in Nazi Germany was one small eye-opening. In your readings and research, did you come across reference to the Alberta eugenics movement, and would you have any comments about that?
You know, I just read really briefly about that a little bit, and there was one in the U.S. as well, right? Around the same time. It was a fairly popular concept at that time, but I don't have any big reading on that. No, sorry. Don?
I guess just one comment. I think we're luckier in peds, but for any of us that have friends or family that are adults in the system, they don't, if you ask them who's your doctor, they can't even identify a doctor that they would say, this is my doctor that I have a relationship with.
Yeah.
And I think as medicine becomes more subspecialized, it doesn't matter whether it's cardiology, nephrology, whatever it is, there needs to be one go-to person for every patient that frequently uses the system, so that they can at least identify, this is my doctor, and despite who's doing the day-to-day management, this is the person that is always there when we're making major decisions. And I think that's, from our services perspective, something we hear all the time from families is, I just want one person who knows what happened last week and last month.
Yeah. And you know, that happened in clinic yesterday. We suggested a treatment, and she said, I just want to ask my pediatrician, because I see her every week, and I see her often, and she knows me, and she knows my child. You know, I just want to go back and talk to them first before I do this. So, just before I take any more questions from here, I'm supposed to ask and see if there's any questions from the telehealth sites, so we don't ignore them altogether. Any questions from elsewhere? I guess not. We can continue our discussion then. Daniel?
I think your second statement there is not talking about technology. The second statement is what's the medicine all about in terms of societal versus patient. Technology is like a stethoscope. We use the stethoscope as a tool. Technology is a tool. Technology makes us better, try to find new ways society as a major thing. That's what you're asking about. And that's what the Nazi Germany tried to do.
That's right.
And that's what the danger of that second statement. I think everybody here uses technology like the stethoscope, my laryngoscope. But when I see the physicians that have patients in the ICU and they follow these kids for a long time, and then I am the first physician to talk to this family about what about not doing this any longer. And the physician doesn't show up for that patient that he knows and she knows for a long time. That's when we are going to the second thing, is we are doing medicine not for that family, we're doing medicine for society. I do my responsibility and I go home. But when the physician comes every day and sees this little Johnny that is now has a bad pneumonia in the hospital, and he talks to me, and he comes back to me and says, Daniel, what do you think? You are the specialist. I don't understand this. You have training on this. Let's talk together. And I say, no, yes, I can tell you about this. But you know this family. What are the values that this family has? What kind of things that they value should we together talk about this? That's the first medicine.
Bob?
In the university setting, we have multiple roles. What we're trying to do in community pediatric clinics, at least time to time, is put emphasis on moral commitment to at-risk families, vulnerable families, complex families. And although our clinics are staffed with excellent teachers, I think their first priority is to moral commitment to the families and not to the teachers. Throw that up.
Good comments. You have a comment?
Well, I was just going to say that, you know, I do think we use technologies like the stethoscope, but they also use us as much as we use them. We don't have to just think about something simple like the stethoscope or the newest template, but also think about technologies like the medical record, right? Which change the way we start to practice and interact with our patients. Because, or even with each other as other physicians, I don't have to phone so-and-so and say, what did you think of the chest x-ray? I just go on the record. So it may cause us to practice more and more independently, even though we're practicing more and more together. So I think it's unfortunate if we look at technology too much as a tool, because it's a lot more than a tool.
Good. I think we'll end with that note. Hope I've made you think a little bit about how we do medicine, and the future will continue to change, I think, and so we'll have to think about this again. I'll see if I can get rid of this slide first. Manjula emailed me and said that she's in Nepal, and so asked if I would introduce myself and welcome you to Grand Rounds. So for those of you who are in the auditorium here, you all know who I am. But for those of you on the video conference, you may not know. My name is Karina Majasic, and I'm a pediatric respirologist. The topic today, though, does not relate specifically to pediatric respirology, but more general to medicine and how we practice medicine. I had a sabbatical now about a year and a half ago, during which I spent a little bit of my time looking at the physician-patient relationship and how it has changed in Western society, in our Western medicine. And that's what I'd like to talk about today. So you might ask, why would we bother with the physician-patient relationship? But it is changing, and it's changing fairly rapidly in our society and in how we do medicine. And I would suggest that it's going to continue to change, so that it is up to us as physicians and other healthcare workers to look at how do we relate to our patients and what is our role in healthcare. I'm going to speak about the physician-patient relationships for two reasons. One, I am a physician, and the other one is that is the relationship that we have historical data on. But I think from anybody who is involved in patient care, how do you relate to your patient is a question that you have to ask yourself. What I hope to accomplish today, and what I hope that you will get out of these rounds, is that I hope that it'll give us a platform from which we can look at the physician-patient relationship and how it changes in the future. And I hope to give you a historical overview where it has been and maybe where it is going. I come at the talk from a number of different sites, so we're going to have to switch gears a few times throughout this session. I first want to look at a little bit of the definition of the physician-patient relationship and how people have tried to define it in the past. I want to look at studies of the physician-patient relationships. What difference does it make, if any? Then I want to switch gear and look at the historical trends in the physician-patient relationship. And as we go along, I'm going to try to pull out the philosophy behind the physician-patient relationship as much as I can. And then I'm going to end on what forces today in our society are acting on the physician-patient relationship. I'm not a philosopher by training or by anything. And so what you're going to get is a bit of an overview. It's a 45-minute session. I'm not going to go into depth on any of these topics, but hopefully give you sort of an overview of the topic. So if you look at the physician-patient relationships, people call it by many names. It's the cornerstone of Western medicine. It's a privileged relationship. It's a professional relationship. And you see all those words come up. But really, what is the relationship? So before we go to that, to go to the classification of the relationship, we want to look and see, does it really matter? Are we talking about something that is of importance to anybody, or is it just a historical fact? There are a lot of people who have actually studied the relationship between physicians and patients. I was a little surprised when I first started to look at it that there are a number of studies out there. If you go into PubMed and you put in physician-patient relationship, you'll get 50 to 60,000 articles up. So it's not a non-study topic. But the studies have uniformly showed similar findings, that if you have a trust in the physician, that improves patient outcomes. If the physicians and the patient rate the relationship as a good relationship, that improves patient health outcomes. And one of the family practice or general practice journals said that, this is quite significant, estimating that 40% of deaths are caused by modifiable behavior, things like lifestyle changes, quitting smoking, healthy exercise, healthy eating and exercise. So that if you can modify that by having a good relationship between the physician and the patient, those are significant outcomes in healthcare. There was one meta-analysis on a number of the studies. There was 106 correlational studies and then 21 experimental studies that was included in this. And they had the same report, that the physician-patient relationship, if it was rated as good by the physicians and the patients, then the treatment had better outcome. So what determines then, what are determinants of a good relationship? What factors go into a good physician-patient relationship? And one is the strength, and again, this is kind of an overview of it, but some of the things that went into determining a good relationship was longitudinal relationship. The fact that the patients were able to see the same physician and build a relationship over time. So a longitudinal relationship. And then the depth and the strength of the relationship was related to 4 domains. One was the knowledge of the physician, that they felt that the patients felt that the physician was well informed about their illness. Trust in that the physician knew what they were doing and also that they wanted to do the best for them. Loyalty and regard. So very human characteristics, apart from the knowledge bit, which is it's the knowledge of the scientific, but the rest of the domains, the 4 elements, are actually relating to relational aspects rather than to scientific knowledge. So again, here's another study that shows the same thing: competence, honesty, integrity, knowledge, reliability, respectfulness, sincerity, and understanding. And what struck me with this is that a lot of what's being rated high here is human relational qualities rather than, do I know my science, do I know my medicine, in terms of factual knowledge. But it's the human interaction that is being rated. So if we look at the patient-physician relationship then, it can kind of be broken down into 2 components. One is the medical competency. Can you come to do you do an accurate history, accurate investigations? Do you maintain confidentiality? All those licensable qualities. But there's also this relational aspect with the patient that we have as two human beings that are meeting. And that is what I want to try to focus on today. So there's been many attempts at classifying the physician-patient relationship. This is a classification that I found in the literature as well, and it classifies the physician and the patient's role. And I have modified it. The yellow one is a modification by me to sort of take it one step further from what they were at. So active-passive, the physician is active, the patient is passive. The physician holds the power, the patient is passive. This is what people have called the paternalistic relationship, where the physician was paternalistic. A physician cared for the patient. And this may not exist in its true form anywhere, but this is the relationship that was paternalistic and that has had a lot of backlash in terms of what people think should be. We'll come back to that in a little bit. Then there was the guided cooperation, where the physician provided guidance and the patient sort of cooperated. The mutual participation with more emphasis of patient-centered medicine, patient-centered care, and more of an adult interaction. And then the passive-active, and this is where the patient determines what they want, what they are entitled to, what they should have, and the physician provides the medical technical expertise. And there's a few examples of this in our current practice of medicine that we'll come to in the end. So I want to say that it's very difficult to sort of put the physician-patient relationship into a box like that, because most relationships are not simple one-to-one relationship. In pediatrics, we know that, but even in adult medicine, it's usually not just between one physician and one patient. It's between families and the physician, nurses, other healthcare workers. So to just make that relationship is very difficult. There are many aspects to the relationship. Which physician do you choose? Do you even show up for your appointment? Do you want to participate in your treatment when you go home? There's lots of aspects to the relationship, and most of the studies would refer only to the decision-making aspect of the relationship rather than the whole relationship. And then I would point out that different relationships are appropriate at different times. So if I have terminal cancer, I would like to be a participant in the decision-making about what treatment I would undergo. I think that's very appropriate at that stage. But if I have an MI outside of emergency, I don't need any consultation as to what treatment I want. I would be very happy if somebody would just look after the situation and institute CPR. So the situation dictates as well as to what relationship is the right one. And so what we can look at is just the general trends and the changes rather than this is what it should be in all situations. So I'm going to go back and start with history. So there is medicine prior to the ancient Greeks, but the ancient Greeks are generally credited with having started Western medicine, although there is evidence that the Egyptians had a fairly high form of medicine before. But we're going to go back to Hippocrates and look at the era in which the Hippocratic Oath was stated. Then we're going to move forward in time and sort of look at modern medicine and how things have changed during modern medicine times. So the ancient Greeks were a society not all that different from us. We think of them as, old and different from us, but they're very pluralistic. They had all kinds of different citizens with different roles. They were a democratic society. They approved of suicide as a method of improving society, and as a matter of fact, suicide was often encouraged for people who didn't contribute to society. They improved of infanticide by exposure of unwanted infants or handicapped children. They approved of abortion. So they had a society that was quite liberal, quite pluralistic, and a society where medicine was often for sale. In the early Greek times, the physicians would participate in selling poisons for suicide. This was part of what their society deemed as right and good for society, and also in terms of induction of abortion. So medicine for profit, for selling, participating in medicine. And it was in that setting that the Hippocratic Oath was actually started. I won't go through the Hippocratic Oath, but I thought I'd bring a slide of it. It's not that long. But it is a covenant statement between the patient and the physician. And that's what I'm going to focus on a little bit. It is also a covenant between the physician and his teacher to do what is right for the teacher. And it's also between the physician and the god, or the gods at that time. So it's a covenant that has three parts to it. And it was binding on the physician, but it was not binding on the patient. So if the patient came to a physician of a Hippocratic society, they knew what that physician practiced like, because this was the oath that they had taken. But it was not binding on the patient that they had to go to that physician. It was stated before the training began, so it was a commitment to how you were going to practice science, the science of the time, and the technical knowledge that you had before you started to train in that knowledge. And it was not a consensus statement. It was formed by a small number of physicians who followed this particular school of thought, but it was not by any means consensus among all the physicians in the Greek time. It has been modified over times by the Judeo-Christian values and by the Islamic values, but for most parts it has served to guide medicine for many, many hundreds of years, into the 1700s, 1800s. It served as the model for medicine. So the underlying philosophy in the Hippocratic Oath was that there is an ultimate authority, a God, that determines right and wrong. You are, as a physician, you are benevolent towards your patient. You look after them. The patient needs comes first, even before your own needs. And in some ways, you would determine that it's paternalistic. You look after the patient as the physician. So we're going to come back in history. We're going to move up to the 1700s. In 1700s, medicine was mostly a treatment of symptoms. There was very little understanding of the disease itself, and the pathophysiology was minimally understood. So it was mostly focused on relieving the unpleasant symptoms that the patient complained of. The society was very hierarchical. Medicine was symptom-based. Patients were usually upper class. And the physicians actually competed for patients. So it was very important to be patient-centered and patient-focused, or you didn't get the work. So you were very focused on the patients and the patient's family to do what was best for the patient and what they wanted. So the patients were very much in charge. The problem was that most patients couldn't afford medicine, and so it was only available for a few. So the underlying philosophy here was a caring relationship, paternalistic relationship, and very patient-centered care. In the 1800s, we discovered germs. And the focus of medicine shifted a little bit from the patient's symptoms to the pathophysiology of the disease. How did the disease come about? If we can understand that, we could treat better. And so the focus shifted away from symptoms of patient complaints to the disease process. And the emphasis changed slowly from the comfort and healing role of the physician to the science of medicine. So from the art to the science. Today, to jump forward and skip over a little bit, physicians are often telling patients they have disease before they even have symptoms. We do neonatal screening, and we announce to the family who has a completely healthy-looking newborn baby that your child has an illness and that we need to do something about. So we're quite far removed from the feelings and the symptoms of the patients, and they were now trying to tell them that they have illness when they look and feel completely well. And we also talk about risk factors. And so we have a real big focus on the science and the understanding of pathophysiology, but not so much impact on what the family are feeling or experiencing. I want to backtrack a little bit into history again and talk about hospitals. There were hospitals in the ancient world, places of healing, often places of religion, Egypt, Roman times, medieval Europe. But modern hospitals started to come up after we had some science, some of the modern science in medicine. And they were based on the science and the technology. They were very much improved places for medicine. They were cleaner. You could control the environment much more than in your home. They allowed people who were less affluent to be able to buy a space in the hospital for their disease, for treatment of their disease when they could not accommodate it in their home. But they were less private. They were less patient-centered. The family was often not there, and they were less personal in that staff would come and go. The staff was not all the same. Your family was not there with you. It's estimated that between 1880 and 1920, the center of medical practice in the United States moved from the home to the general hospital and has, for most part, stayed in the hospital. So the underlying philosophy here is probably that values are still to look after the patient, but the science of medicine is more important, and the art starts to take a second role. I'm going back to history again. I want to just step off the scale a little bit in terms of the things and stop in Nazi Germany. And because here's one point where the philosophy of science actually changes. I want to talk a little bit about the eugenics that happened during Nazi Germany. In the early beginnings of the Nazi German regime, there was a big movement under social Darwinism and the racial hygiene movement. And the medical profession and the scientists thought that they knew how to improve on the human race, how to make us better as a human race. And so in 1933, there was a law that prevented the progeny with hereditary defects, basically compulsory sterilization. In 1937, expert doctors provided a program of sterilizations of all German colored children in order to improve society. In 1939, the rights were extended to specially designated physicians to treat patients who were judged incurable after the most thorough review, and then they would treat them, grant them mercy killing. There were 200,000 questionnaires sent out, and through that process, 75,000 people were basically euthanized because their lives were deemed not to be worth living. The physicians participated in this program. The program was not compulsory for physicians, but they felt that they were doing what was in the best interest of their society. It was compulsory for the patients, but not for the physicians. So there was a shift in the philosophy of medicine, that the philosophy of medicine was that the science as understood at that time was to be used for what is best for society, rather than what is best for the patient. And so the physicians worked not for what's the best interest of the patient, but what is the best interest of society, based on what we understood of the science at the time. Okay, that's it. We all know the history of this. After World War II, there was the Declaration of Geneva, which redefined the physician-patient relationship, and we now try to have legislation and declarations that will stop this kind of thing from happening again. And out of this came an underlying philosophy where we have respect for the autonomy of the individual, so that patients have to consent to treatment rather than be part of treatment that they would not consent to. So I want to come back now and talk a little bit about our society. How has society changed, and what are the changes in our society that influence the physician-patient relationship? I think we have to keep in mind when we talk about societal changes, those that we also, as physicians, we also live in society. So we are also part of the influence of the societal changes, not just the patients. So we have an increase in information in our society, both an increase in total amount of information, but also an increase in access to information. And that applies to us. It also applies to the patients that we see. It's estimated that 52 million adults that 52 million adults in North America look to the internet for their health information. So that's good. That's also bad, because everything on the internet is not good. You can post what you like, right? So good and bad information, but information nonetheless is available to a lot of people at very easy access. The other part I would like to also say that we are a consumer society, and we've often heard that about ourselves. We have an industry that encourages us to be consumers. We have marketing industry and advertising industry just encouraging us to tell us that we need something different, that we need more, we need this, we need that, we should not be happy where we're at. And we should also shop until we get what we want. That applies to us as physicians. We are taught that same message. It also applies to our patients, that they're taught that you can shop till you get what you want. So how does that affect our relationship? Well, we have consumer medicine. In the United States, it may be a little bit more obvious that they have consumer medicine, but I would say in Canada we also have consumer medicine. Many healthcare providers refer to their patients as clients. They are our clients. They come and shop for what they want from us. They're not a patient anymore. The patients have become consumers of medical services, and at times this concept of autonomy have at times become synonymous with the patients should get what they want because they know what's best for them. So that we've moved from sort of the benevolent to the patient shopper, consumer of medical care. If we take the autonomy, patient get what they want attitude to its logical extreme, the physician then becomes a provider of a medical technical expertise, and the patient shops until they get what they want. But the result of that is that as a patient, you can no longer be sure that the physician has your best interest at heart. But they just have to be assured that they know that you know what you want. So that it moves medicine into a realm of you're on your own, shop till you get what you want. An example of this kind of medicine is the story of the Octomom. And I think we probably all know the story of Nadia. She's a single mom who expresses an interest, or a single lady who expresses an interest that she has difficulty getting pregnant, but she wants to have a large family. And so she undergoes in vitro fertilization, and she has 6 single children through that, and comes back for one more round of in vitro fertilization. And this time, she is adamant that she wants all 12 embryos implanted. So she declares that is what she wants. She wants all the 12 embryos implanted. And as a result of that, gives birth to 8 premature babies. So in the extreme model of the autonomy of the patient, this would be an okay thing to do because she knows what she wants. The college and the boards of medical colleges don't think so. As a matter of fact, that physician was held accountable for being negligent and not looking out for what is the best interest of the patient. And he actually lost his license to practice medicine over that. So that brings me back to one of the other things that's a little bit unclear in medicine at this point in time, where on one hand we have the autonomous patient who knows what's best for them, and we have a physician who has responsibility towards that patient to do what's in the best interest of the patient. And one of the things that I would see would need to be sorted out over the next number of years is exactly where is that balance as physicians practice medicine. Where does the patient autonomy and the physician responsibility meet in medicine? So we have changes in medicine too. There's been a tremendous increase in the medical science and technology. And there has been a diminishing art until fairly recently, or diminishing interest in the art and philosophical basis of science. And although I would say that statement, the tide is turning a little bit on that, and there is becoming more of an interest in the art of medicine. Just to give you perspective, in 1989, which is not that long ago, the Human Genome Project began. It was sort of completed in 2001. It cost $3 billion to complete. 2011, you can buy your own gene sequencer for $50,000 to put on your desktop in your lab or at home. The information of genetics have skyrocketed in publications. And you can now go to the internet, you can go to 23andMe, and you can contact them, set up a profile with them, give them a little bit of information about them. They will send you a kit, and you spit into the tube, and you send it back to them, and they will sequence your DNA. They will send you a report on what your risk factors for various diseases are and what your ancestry makeup is. You don't need any medical background. Anybody can sign on and do it and just find out what's your racial makeup and what's your risk factors for various diseases. So there's a change in how the patients access information. So as the physician, you may today have somebody come to your office and say, you know, I have risk factors for this particular disease. What do you recommend that I do? Where they already have the DNA sequenced for that. There's also been a shift away from primary care to subspecialty medicine. This is a quote that I read somewhere along the line. I don't remember which person said it, but I thought it was quite good. Is to know more and more about less and less. And so that we specialize in certain areas of medicine, respiratory medicine, cardiology, pulmonary hypertension, and we get all these small little niches of medicine that we are specialists in because the information is growing at such a rate. But it shifts the focus in our relationship with the patient too, because if all I do is look after lung disease, then who's looking after the whole patient? And so it makes a difference in how we practice medicine. The other change in medicine that has occurred is most physicians no longer practice solo practice. When the Hippocratic Oath was stated, and earlier on, even up to the 1800s, most physicians practiced by themselves. So they had their patients that they looked after. But most of us practices in group practices. We have colleagues, we sign over call. We're not on call all the time for our patients. We don't do house calls. We're not available all the time. And multiple physicians like myself also practice in a hospital settings. So the patients have difficulty having a long-term relationship with one physician who's always available. And often in the hospital setting, we also have influence from the hospital who dictates when and how we can see patients and what we can do. So these all are influences that influence the patient-physician relationship, how we practice medicine. And then last, medicine has evolved into the broader area of healthcare, preventative medicine, screening tests, risk factors, prenatal screening, no longer looking after the patient with the illness, which was the original model for medicine, but now trying to prevent the disease and working with them in that sense. So this is just to state that. The other thing I want to bring up is who do the physicians work for? We don't initially in healthcare, the families hire the physician or the patient hired the physician. So you work directly for the family. You had responsibilities to the family and they had responsibilities to you. And so it was very much an adult type relationship. You had responsibilities to each other. We have had socialized health care in Canada for a good number of years now, and all of us work basically for the government. We work for the healthcare system in some way or the other. And the patients have a relationship with us as a provider of healthcare within that healthcare system. They don't have a direct financial relationship with us. But that also puts a different slant on our role. What is our role? To look after the patient directly or to look after all the patients in the healthcare system? So we have obligations to the healthcare system as well as to the patient. It pushes the patients to have a relationship with the healthcare system rather than just one physician, and to try to become consumers of medical services available to them rather than the direct relationship. And it makes the patients have a less trusting relationship with the physician, and the physician to have less of a commitment to their patient, because it becomes our patient rather than my patient. So who speaks for the patient then? If the physicians are now working for the system, and who, to some extent, who speaks for the patient? Well, the family often does. There are patient advocacy groups that are coming up, and maybe it should still be the physician. Maybe that is still part of the role. So patient advocacy groups, there's actually a patient association of Canada where patients can go and get information on treatment and things. And it was interesting to go to their website, and I've just put one quote up here, but the quote was from one patient who had contacted them. Most of their quotes and most of their statements are very similar. That I was referred to a specialist who saw me 4 days later and diagnosed me with cancer in a very matter-of-fact, who cares kind of way. He was, at best, an accurate diagnostician. No empathy there. Again, there's not a criticism of the science and the technology. The criticism is of how we practice medicine. There was no empathy. U.S. News and World Report have a section of sort of ahead of the curve, they call it. It's a section on up-and-coming careers sometimes. And so they studied what are the up-and-coming careers, and the two careers that they name is health informatics specialist and patient advocate. Predicting that in the future, patient advocates are going to be used by both hospitals and healthcare institutions and families to help them navigate through the system. I find it a little scary when I went to see what does it take to become a patient advocate. And really, it's a very self-selected group, but there are people who care for other people, people who are empathetic. They get information on how the healthcare system kind of works, and then they are going to help the patients through the system. So the advocate role for the family on a personal basis is a bit lacking in medicine at the moment, and there are people who are stepping into that role. So if we're going to look at these relationships, try to sort of dig them out a little bit, what do the relationships look like? So we have the physician and we have the patient. And this was the simple model initially with the Hippocratic Oath, one physician, one patient, how they interacted together. We now have the physician also interacting with other physicians and making a sort of a multiple physician teams, other staff, hospital policies, hospital administration. We have university interacting with the physician, particularly in a teaching hospital where there are students, there are research projects that compete for the interests. We have other organizations like the College of Physicians and Surgeons. We have CMPA. We have other agencies who want to also have a say in what the patient-physician relationship is. We have the payers, Alberta Health Services in our case, but in other cases they insure people who are interested in how many patients can you see, not only what you're doing to one patient, but how does this play out in the public, how does this play out in the community as a whole? Are you spending too much money on one patient, or who is advocating for the whole population? And now we also have patient advocacy groups who want to speak on behalf of the patient and who also want to have a role in how does the patient-physician relationship look. So this relationship that started out being very simple with one physician and one patient is kind of becoming bogged down with all these other interests, some of which have really advanced medicine, advanced science, and they're not all bad. But I think they're making it more difficult as a physician to know what is your role as a physician with your patient. I want to just point out that there has been a turn in the tide from science-only medicine. In the 80s, there were a number of physicians who felt that medical students and young physicians were very well trained scientifically and technically, but they lacked caring and compassion. And through that, the Gold Foundation was started. Our medical school subscribes to the Gold Foundation. They are a member of the Gold Foundation. And the idea that they had was they needed to nurture and preserve the tradition of the caring physician, the physician who looked after their patient. I don't have the slide for it here, but with this, our medical students here say an oath at the beginning of medical school or a statement of standards, practical standards. They also repeat that and enhance that at the beginning of their clinical year, and they do take an oath at the end of their medical training. So there is a turn in saying, look, we need to look at where the tide is going. Is it all science and technology, or is there also the human side of medicine, where you have a relationship with the patients and you look after the patient and you care for the patients? So the challenge to us, I think, is that medicine is changing, and it's changing rapidly, particularly with respect to the technology and science available in medicine. And we need to be part of the discussion that defines how physicians and patients interact. And we need to look at our own practices. How do I practice medicine? We need to address the question of patient autonomy and the physician responsibility in relation to each other, where they meet and how they meet. And then we need to try to structure the environment that can enhance the physician